I would like to welcome you on our SAME-NeuroID last seminar. This is the last SAME-NeuroID under the sponsorship of this project, and from the next seminar we will start the new seminar series under the sponsorship of Teaming for Excellence. And today we host Dr. Monika Matusiak from the World Hearing Center at the Institute of Physiology and Pathology of Hearing in Kajetany, close to Warsaw. She's otorhinolaryngologist, and she's interested in the neuroplasticity in the auditory system. And today we will hear about the transfer of the knowledge about the molecules, of the molecules, to the therapy of the auditory systems.
Thank you. Thank you very much for this kind introduction. First of all, I'd like to thank for invitation to this wonderful research center. I'm especially honored just because I don't feel myself a scientist purely only. I'm one leg a clinician, and the other leg, my other leg is in science, in research, which personally I find the best combination to be both doctor and a scientist, but it's at the same time very demanding combination to be a clinician, to deal with patients, and to do research. So this gives me the ability to. This gives me the perspective to appreciate the work done by scientists and by true researchers even more. And I think it's the progress and all the interesting things we as clinicians, the tools we as clinicians are given, they come from you. So everything starts in basic science. So that's why I'm really, really honored to be given the possibility to present and to talk to you and to present the results of my interests and the work we've been doing in Kajetany. So, as I said, I'm a clinician. I work in Institute of Physiology and Pathology of Hearing in Warsaw. I'm otorhinolaryngologist. It means that I take up a hearing. Otolaryngology, of course, is not only hearing. We call ourselves sometimes surgeons of head and neck, but it is very broad description. I personally am involved in hearing treatment, in different kinds of hearing diagnostics and treatment. For like 15 years I work in Kajetany, which is a huge institute, mainly clinical. We have a huge branch, which is just a hospital with many very busy hospital with many different kinds of hearing disorders. And one of those disorders, one of the sub branches of our clinic is the congenital deafness. So congenital deafness is a condition when a child is born without ability to perceive environmental sounds. There are many reasons, of course, for congenital deafness. There can be both. This could be either genetic, could be due to some prenatal factors, perinatal factors, or could be acquired just after birth. But still, it leaves the child without any capability to receive sounds. The condition's pretty frequent. It's like 1 to 3 cases per 1,000 live births, so it's not that rare. And if it's not treated, then it brings dramatic consequences just because the child is unable to develop speech, is unable to communicate. So basically the child become mute. So we can easily imagine how dramatic life of those people is. So for over 20 years, 30 years actually, worldwide and also in Poland, congenital deafness is treated in the standard way by cochlear implantation, which is a wonderful device, absolutely genius. And it can treat deafness very effectively. It means that this is kind of a device which we implant into the middle and inner ear. So this is device is there is an internal part which is implanted. So we just have to put it into the temporal bone, and there's an external part which is worn out on the skin, as you see here. This child is having his speech processor. So this is where sounds are received, and they are transmitted to the internal part, and then through the electrode, the sounds which are converted into electrical pulses, they are transmitted to the cochlea, to the human cochlea, which is not working at that time. I mean, the organ of Corti is not working, but this, which is spiral ganglion cells, spiral ganglion fibers, they are working. It means we have to have a nerve, a cochlear, the auditory nerve has to be present and has to be intact to be able to perform cochlear implantation. But this is, of course, the majority of cases of congenital deafness. If the congenital deafness is due to genetic impairment, it means one of the cells which build the organ of Corti, one of those, this organ is not working, right? So it's not working, right? So then we deliver electrical pulses into the fibers of spiral ganglion, and then they are transmitted to the auditory cortex. So now we see that this is a temporal lobe, this is auditory cortex, and the cortex has been stimulated by the electrical pulses delivered through cochlear implant. So this is a wonderful device. It has completely changed the landscape of childhood deafness for like 30 years worldwide. There is it's used not only in congenital deafness nowadays. Primarily, it was designed to treat congenital deafness. Now, the indications expanded enormously, and we also treat patients with acquired hearing loss, like adults and even elderly population, which lose hearing just because they are old and or they acquire hearing loss due to some noise exposure or whatever. So, but anyway. What I want to say is that this is absolutely efficient, great device. Those children implanted, most of them, they enter public schools, they develop speech absolutely normally. They enter normal schools, they go to universities, they are educated and they start just a normal life. So now I can show you how well a child can speak when it's implanted. A deaf child, this girl, the girl on the left side, she's been implanted at the age of 10 months. They both were implanted. Yeah, so this is how these children can speak when they are implanted early enough, just to deliver electrical pulses to the system within the sensitive period of plasticity for in auditory system. Again, there are. As I said, we have in general the outcome are very satisfying, but still there is some spread of outcome of the outcome of cochlear implantation in congenital deafness. So how we measure the success of cochlear implantation? We measure it by auditory development, by the ability to understand speech. And it's pretty tricky in children up to 5 years to measure this speech understanding, but there are some tests and questionnaires, so we can somehow evaluate it. But again, this is a very good graph presenting results of the speech understanding, the score of speech understanding of children implanted early. This is the age of implantation. And we know that was in the previous slide. We know that there are factors. There are factors which still influence the outcome. Those factors which are known, which is that age at implantation is a very important factor. So the rule is this: the sooner, the better. The shorter the duration of deafness, the better outcome. Of course, comorbidities. For example, we have children with syndromic deafness, many of them, like Down syndrome or many others. They hugely affect the outcome of cochlear implantation. Etiology of deafness, as I said. If it's purely genetic deafness, then it's quite easy. When it's deafness acquired due to exposure to virus, for example, then the prognosis is much worse. Of course, the socio-economic status of the family is also important, just because the involvement of parents into rehabilitation is also very much important. But going back to this variety of outcome, we see that, again, having children implanted early, which means in the first 2 years of life, we still see a big range of outcomes. It means that we have children who acquire ability to develop speech and verbal communication almost at the with the same result as normal hearing children. The gray ones are normal hearing children, and the yellow are implanted children. But again, we see there is a group of children who develop speech much slower. And again, even though a huge effort of rehabilitation team, they never reach the fluency of their normal hearing peers. And we do not know why. One of them are, as we call them, star performers. So they are implanted and they develop it very fluently, easily, as I said, almost as normal hearing kids. And we don't know who of them will be at risk of speech and language development. So, as I said, as a clinicians, we would love to have a tool which would allow us to identify children who are at risk of success of speech and language rehabilitation before cochlear implantation. Because if we would know that we can somehow identify those kids, if we would know that a kid coming to our clinic at the age, let's say, 6 months or 3 months or 4 months for diagnostics, we do diagnosis, we know that it's bilaterally deaf and we have to implant it, then first we would know how to consult the parents, which is very important, just because parents expect from us, they would be happiest if we would say to them, we guarantee you that your child will develop speech like a normal hearing sibling. But we can't say that. We don't know. So we really don't know which of our patients will develop it quickly, successfully, and which will need a lot of effort and still, even though, will not reach the 100% of understanding, literacy, and everything. So to answer the question where we should look for another factors which influence the outcome of speech and language development, we've tried to look at the process of language formation from the perspective of interaction between implant and the brain, because the brain responses to the delivery of electrical pulses by formation of language. So the process, as you, of course, all know better than I, then the process is neuroplasticity, that is the ability to form the connections between neurons. That is interesting just because in the conferences for clinicals, for clinicians, this is a slide which I have to explain, takes me the longest time to explain. And now I think I don't have to explain it at all, just because you know very well what is neuroplasticity and how it works and what is synaptic plasticity and everything. So we've been looking at the synapses. So this is where the whole play of the strength between the pre and post synapse takes place. So I had an honor and a huge pleasure to cooperate with Professor Leszek Kaczmarek from Nensky Institute in Warsaw. And we have looked at the molecules involved into intrasynaptic play. And we have focused in our research on two particles involved in intrasynaptic play, in this synaptic plasticity. This is MMP9 and BDNF. They are both particles of known role in neuroplasticity in different clinical, physiological and pathological conditions. For example, they both are involved in neuroplasticity in mood disorders, in autism, in schizophrenia. So we thought that it would be interesting to check whether they significantly impact the ability to respond to cochlear implantation in our children. Yeah, so this is brief, just a brief summary. We all know that there are SNPs, as each gene has SNPs, so MMP9 and BDNF have. So we have focused on a few SNPs. I'll tell that in the next slide. But first, we have focused on a very narrow group of children. So we have selected children with bilateral sensorineural hearing loss over 80 dB, which means they were basically deaf bilaterally. And we have enrolled only children who were completely clean in terms of any other coexisting factors. So we have excluded any other factors which could influence the outcome, like no prematurity, no viral infection during pregnancy. So I was very, very meticulous when enrolling children in terms of going into the medical history of children, because I've excluded all children which could have any other coexisting factors. And those children were implanted with cochlear implant before they finished second year of life, which means quite early. And again, we have looked at some SNPs in both in MMP9 and BDNF, and we also assessed the plasma level of MMP9 and BDNF and also pro-BDNF in the peripheral blood of those children. So we had a group of we had two groups. We've done retrospective study and prospective study. So retrospective study, we took the material from our database in the institute. Again, we've chosen only very clean children. And we have focused on this group this is etiology of deafness. So these are children who had their deafness caused by pathogenic variants in GJB2 and GJB6 gene. So they were clean in terms of any other medical conditions. They were only having pathogenic variants in GJB2 or GJB6, and we had exactly 100 of those kids. And we have divided them in terms of age of implantation, because as I said, this is very important to look at children in a very narrow homogeneous group. So the term on the time of implantation and the duration of deafness is very important in terms of the outcome. We done also prospective study, which was in which I have enrolled 61 children. Out of them, 40 were deaf and GJB2 or GJB6, and again, we have also divided them according to the age of implantation. The auditory outcome we have been assessing during this questionnaire. This is a parental questionnaire, 35 answers, yes or not. Well, this is validated, internationally validated questionnaire used by many centers, cochlear implant centers across Europe. So it's a routine tool. So the hypothesis was that a specific set of genetic variants of those two genes can serve a prognostic factor for outcome of our children. And in a retrospective group, we have assessed those children up to 24 months after cochlear implantation. So we have implanted them, then they started the rehabilitation process, and we have assessed their progress in language development by using the Little Ears questionnaire up to 24 months. We have assessed 1, 5, 9, 14, and 24 months after cochlear implantation. In the prospective study, we did the same, exactly the same, but we had different time points. We have observed those kids only up to 18 months. And here is the results of the first hypothesis. And we have found out that in our retrospective group, we have found out in a linear regression model, we have found out that this SNP of MMP9 affects statistically significantly the outcome of cochlear implantation in every follow-up, right? And surprisingly, we also showed that girls, they were better than boys in the outcome of cochlear implant in the auditory development. In a prospective group, we have found very similar analogical relation. This is a comparison of means, and we have found that the same SNP differentiate results of auditory development between carriers of CC and CT variants of this SNP. And again, the children who are carriers of less transcriptionally active variant of this polymorphism, they score significantly higher after 18 months of using cochlear implant. So that, for us as a clinician, that was really, really interesting. Here we have this analogically, we looked into the subgroup of kids implanted above first year, again with the children with GJB2, GJB6, so genetically based deafness in children implanted after first year, but before the second birthday. We have found exactly the same relation between this SNP and the outcome. And we see that the difference between carriers of CT and CC variant is really large, just because there is almost 6 months of auditory delay. We can transvert points of Little Ears questionnaire into months of auditory delay. And we have found that a kid who is a carrier of CT variant, which is more transcriptionally active, they are almost 6 months delayed in terms of auditory development, comparing to the kid who is a carrier of CC variant. And again, we have found exactly the same relation when in a prospective group. The children who had a longer period of deafness behind them before cochlear implantation, so implanted after first birthday, we see this difference. We did not find this relation in children implanted before their first birthday. So that was also very interesting, which means that probably the duration of deafness, the duration of time the child was without access to acoustic stimulation, it impacts the molecular underpinning of neuroplasticity. Most probably, well, that's our first thought. And again, this is exactly the same, but just to show in picture what is the difference between those two carriers. This is the this is same polymorphism and the observation in retrospective observation. And again, we see that the child who is carrying CC variant scores significantly higher than a child who is carrier of CT variant in almost all follow-up intervals. So second hypothesis we have, which we tested, referred to plasma levels of MMP9, BDNF, pro-BDNF, and also we tested the rate of pro-BDNF to BDNF measured during cochlear implantation, and we checked whether those plasma levels can somehow be indicative of outcome of cochlear implantation after 18 months of rehabilitation. And so this was done only in our prospective study, just because those kids were enrolled, and we had the opportunity to sample blood during the procedure, so that the child was anesthetized, and at that time we could harvest blood. And here we have found a very interesting relation again. So we see that this is statistically significant. We see that children who started, here is the MMP9 level, here is the LEAC score, the auditory development. So we see that children who started their rehabilitation process with the MMP9 below 150, almost all of them score very well. So like 32, 33, 35, it's almost perfect for us. But we see that children who started with MMP9 over 150, they score differently. They can have good results, but also they can have very poor results. 25, it's really not satisfactory after 18 months of using cochlear implant. And when we looked at the subgroup of children with genetically based deafness, we have found the same relation, but even stronger. Again, children who have been implanted with a very low MMP9, they score very well. And children implanted with the higher levels, they scored differently. So what we can say, we do not have the tool to identify children who are at risk, but we can say that we have a tool to identify children who are not at risk. Tells us it's quite informative for us. So, and again, this is the same when we looked into subgroups according to the duration of deafness before implantation. We do not find any relation between plasma level and the outcome of cochlear implantation in the younger group. And again, analogically to the previous results, in retrospective group, we have found that plasma level measured at cochlear implantation is indicative to the outcome of cochlear implantation in the same subgroup of children implanted at least after 12 months of deafness after first birthday. So that is really, really interesting for us. What I can say as a conclusion is, as I said, that we have some indication whether we can have used the genotype and the plasma level kind of indication for us to say, at least be able to say something about chances of a child for the outcome of cochlear implantation. But even more interesting is the perspective. Because how can we use this? So what we would love to have is that would be fantastic if we could transport those kids into here. So if we would be able to assure every child who comes to our center with deafness that we are able to get to the best capacity of the child's brain, right? So if we would know that a child is coming to our center for like 3 months of age, 4 months of age, and we know that it's bilaterally deaf and we have to implant it, and we know that the child is having like 500, 600, 700 nanogram per milliliters MMP9, and we know that this is not a good prognosis, then it would be fantastic if we could lower the level of MMP9 into lower, like below 150, and then probably the child would be given higher chances to develop speech more effectively. Yeah, so this is a big dream and a, well, kind of direction for future, and that would be really absolutely fantastic if we would be able to help those kids, not even to children who are totally who are healthy, but we have also children who cannot be implanted due to some other reasons, like they have huge cardiac problems. They have to be operated, the cardiac surgery. They have to have it just to save their life. So the first thing is to save lives. So we have to perform cardiac. I mean, not us, but the cardiosurgeons. They have to perform cardiac surgery, and then the child. Then after the cardiac surgery is done, it takes sometimes a year and a half. But we know that at the same time the neuroplasticity decreases, right? So if in such cases we would be able to preserve the capacity for neuroplasticity for those kids, that would be absolutely outstanding. But it's that's hopefully the future. Thank you so much for your attention.
Hi, thank you for this talk. I have two questions. One is about the plasma MMP9 levels.
Yeah.
Is it known if it's something which is patient dependent and they have one level, for instance, above the threshold, or is it evolving with age? And if, for instance, they can be at a lower MMP9 level in the plasma if you check them younger, for instance?
We don't know that. There is no data. I've been looking very carefully in the literature, but I didn't find any data on human data on healthy children. There are some data on children. There are always some clinically affected children, so they're not healthy. So I didn't find any data which I could use as a reference. We had a kind of control group, but our control group, due to also the ability actually to enroll the control group, was the age of control group was like they were matched age with the age those children in the prospective group, those children when they reached the 18th month of using cochlear implants. So they were basically much older. And still, the level of MMP9 is very different. So I would say it's individually dependent, what is the level, right? So we don't know. The MMP9 has a very tight and very complex regulation, which is very interesting, of course, but it's also, that's why it's difficult to find some pattern, how it is.
And my second question is regarding the future direction would be to try to decrease this MMP9. Do you have like a model or animal models that you can use, or do kind of back translation?
Well, no, we don't have a model. That's why I'm looking for cooperation to find a model. That would be fantastic to try to see to try to inhibit MMP9 on an animal model. There is a good model of congenital deafness. There is a good model of cats, white deaf cats. There are two centers. Very good one is Hanover, and the other one is in somewhere in Canada. And they have a vast experience with implanting of deaf cats, mainly to study the cortical development in terms of the electrophysiology, and they perform it extensively on those implanted cats, but this had never been done with molecules. So that would be very interesting to implant a deaf cat and to see how it works with the high level of MP9, low level, blocked, knockout, whatever. So that would be interesting very much.
Hi, thanks for talk. I have one question about, if you know maybe, what is the impact of this mutation for this enzyme for MMP9? Is it more active or?
Say again?
Because the SNP, if it is affect any on, biochemical properties of this enzyme?
Yeah.
This is first question. And second, do you observe any changes in this child, for example, in the by the other conditions, because MMP9 is not only for the for the plasticity, but it is also, for example, in the osteoarthritis or in the degeneration of the joints. It is very often also measured as a biomarker of or in an array, so rheumatoid arthritis. So do you observe any changes in this child?
That's a good point, actually. No, we haven't been looking at those medical history of those kids, whether they have any other symptoms or not. That's a good point, of course. Thank you. And to answer the first question is that, we have this, I have this data, it's published. We have found significant difference between plasma levels of MMP9 between the carriers of CT and CC in at the last follow-up, like at 18 months. There was statistically significant difference between the CC and CT carriers of those two variants. So CC were much lower, were statistically significantly lower than carriers of CT. But actually, I would actually expect that the difference would be more stable, like would be through all the three follow-up intervals, but we have found it only in the last one. So that's interesting. It's not even, we haven't found it in the interval 0 at cochlear implantation. There was no significant difference. There's still a difference, but not statistically significant. But it appeared to be significantly different after 18 months of using cochlear. So
great, thank you.
Any other questions? I have two questions. More general. So do you see so first of all, do you test these children for the cognitive function? And the second, do you see the correlation between the improvement in hearing with the cognitive function?
Yeah, that's a very good question as well. I mean, they were tested. Some. It's first thing is difficult to test a child who is like a year, 12 months, 13 months cognitively. It's very difficult, right? There are some tests who are available to be administered at 3 age of hearing age, because you have to know that those kids biologically they are older than in terms of hearing age, right? Mm-hmm. Because they started hearing after some time of deafness. So they were, but we have not looked at it, and I would say it's quite a rough evaluation. And it's a good point, of course, to check it.
And the second question, you said that when the disease has a genetic background, then it's easy. So I understand that the mutation in those two genes causes the deafness. Yeah, are there attempts to do the gene therapy, for example, or is it possible at all in the because it is, I assume, neurodevelopmental disease, right?
Well, the JB2 and JB6, they are genes which are expressed in organ of Corti, in a different, in an organ of Corti, and they cause deafness. If there is a pathogenic variant that causes deafness, this is the JB2. It's a connexin. They encode connexin. So if the connexin is one of the proteins which build the channel for calcium, I think, and when it's not working, then the whole ion transport through the canals of the inner hair cells is not working, so there is no polarization and no way, I mean, there is no, the organ of Corti, it's not working. So this causes deafness, the insufficiency of organ of Corti, it's the polarization, it will not appear. But the thing you've mentioned, the gene therapy, which is very emerging right now in all the medicine, but also in deafness, gene therapy would change, would revolutionize everything just because they would replace cochlear implants. And there is an ongoing wonderful study done for otoferlin, which is very easy to reach by gene therapy just because it's expressed only in postsynapse. It's very rare, right? Much more rare than GJB2 and GJB6. But it's the results are very promising. So they deliver the normal copy of otoferlin into the cochlea, and it works. I mean, the results are absolutely phenomenal. It's an international study, and they show that it's started in bilateral deafness, so the kids are implanted on the one side, and the other side is treated by the gene therapy. So not to just first to provide the child with the standard treatment, so it could develop language on one ear, and the other ear is treated with gene therapy. And we see that in evaluation in ABR, which is the brain responses, auditory brain responses, which we use to evaluate the hearing threshold, we see that the hearing threshold decreases. It means that the hearing is getting up, right? It's absolutely amazing. But it's a future. GJB2 and GJB6 are much more difficult for gene therapy, just because the expression is much wider in organ of Corti.
Thank you.
I have one question, actually, not biological, not chemical question, rather more general, regarding the diagnosis process of deafness. Because in Poland at the moment, we have this screening program, which area was supported by Jurekowsiak organization for checking hearing by newborns children. And how fast is the diagnosis process? After such a screening checking, is the child immediately directed to your center in Kajetany? Or I can imagine probably some other tests have to be done and so on, but is it just weeks or months? Or
we are lucky as a country, I would say, just thanks to Jurekowsiak and the Wielka Orkiestra Świątecznej Pomocy some years ago, because they covered almost all country, all the newborn departments with the hearing screening, which is very easy to perform just after birth. It's easy. Nurses do it. It's really easy. So each child which is discharged from the perinatology or newborn department is given the certificate whether it has went through the universal screening, hearing screening or not, whether it should be come back for checkout. Because if the first screening is incorrect, then it's performed second time, third time, still on board within first 2-3 days of life. If it's still absent, if it's still incorrect, then the parents are informed to come back when they come back, actually, they are referred to audiologists for us. It necessarily has to be Kajetany, just because, we wouldn't be able to, test all those children, but it's easy test, so it can be performed in any other hospital of outpatient for audiology. It's, as I said, it's easy to perform. And again, if after 1 month, it's still absent, it's still negative, I mean, you can perform it after 3 months, as an audiologist, I would say, okay, come back. Don't worry for now. For parents, don't worry. It can happen, but you have to come for checkout. And after, if after like 4 or 5 times it's absent, you have to perform ABR, which is auditory brainstem responses, which is a longer examination done during, in newborns done during physiological sleep, so overnight, or during the day when the child, it sleeps. And for this, you need qualified technicians, experienced qualified technicians, so it's better to do it in a big center. And this should be done within 2-3 months. It's theoretically, and that's optimal. If it's not done, I mean, I want to believe that all specialists, they know where to send the patient and how to inform parents. They are informed. The other thing is that parents cooperate or not. That's the reality. And sometimes we have patients coming to us, like a child is 1.5 years, 2, the child doesn't develop speech, and the parents say, well, okay, we're waiting. Everybody says you have to wait 2 years. It's not, you still have time. Maybe when it will go to the kindergarten and so on. So, I mean, it has to be a cooperation of parents, because we see really dramatic situations where the child is not diagnosed just because they, I don't know, I don't remember, they gave us something in a hospital. I don't know, I mean, they didn't say anything and so on. So, it's 2 element play. First, parents, second, us, right? So if parents are cooperating, there are no cues for, it's really alarming diagnosis that the child could be deaf, and you have to do it quickly. You have to have diagnosis quickly. It means we have children coming to us at 2-3 months of life. We've performed several tests of those tests done at universal screening. When it's negative, they come for ABR. We do 1 ABR, second, just to cross-check, just to check, we really have to be sure that it's deafness. So we have a number of patients who come like 3, 4, 5 months of life diagnosed, and still we are unable to implant a child which is 5 months just because it's too small. We need like 6, 7, 8 kilo child to perform a surgical procedure, which is quite extensive, really. So anesthesiological issues and so on. So we have to wait. Sometimes we have diagnosis, we have everything, we have very cooperating parents, and we said, please feed the child to get 8 kilo, so we can implant it very quickly, right? But I would say this is a bottleneck. The diagnosis has to be done very quickly, and I believe in the future, maybe the device technology will progress, and the cochlear implant will be smaller. It's getting smaller and smaller, even for like 15 years when I work with cochlear implants. They are smaller, they are more user-friendly still. And I believe the technology will allow to minimize the size of the cochlear implant, because you need an amount of bone, right, in a skull just to sing the processor. So I believe this will come, or the gene therapy will replace cochlear implants, which is also absolutely fantastic to observe and to see what future will bring.
Okay, do you have any other questions? If not, thank you very much again.